Hi everybody, it's Elizabeth, and I'm reviewing an article published in 2010 in the Pakistan Journal of Biological Sciences. It's entitled The Comparison Between Killed and Living Probiotic Usage versus Placebo for the Prevention of NEC and Sepsis in Neonates, and it was conducted by Awad and Associates. For ease of presentation, my iPad will not let me flip back and forth between myself and the computer screen, so I decided to keep it on the computer screen so it will make the presentation run more smoothly. Necrotizing enterocolitis, or NEC, is a devastating medical condition responsible for significant morbidity and mortality in preterm, very low birth weight infants. It affects 7 to 14% of very low birth weight infants and is the leading cause of mortality in this group. Although the exact cause for the pathogenesis of NEC is unknown, several factors have been implicated in the development of the disease, and these include prematurity, enteral feeding, intestinal hypoxia, ischemia, and bacterial colonization. In some cases, the consequences of this medical condition include intestinal stricture, growth delay, poor neurodevelopmental outcome, as well as visual impairment. The intestine of a full-term infant is colonized with more favorable microorganisms, like lactobacillus and bifidobacteria. However, these beneficial intestinal microorganisms did not predominate the premature intestine until about 3 weeks of life. So that's how the factor of bacterial colonization becomes such an important topic in this population. For the article that's being reviewed, the research question is the following: in preterm neonates, is supplemental live or killed Lactobacillus acidophilus safer and more effective at reducing NEC and sepsis when compared to placebo? This study is a randomized, double-blind, placebo-controlled trial conducted at Ain Sham's University Pediatric Hospitals from January of 2006 to May of 2007. The study included 150 neonates admitted within that time period who had a negative initial C-reactive protein, or CRP, CBC, or complete blood count, blood and stool cultures on day 1 of life. The CRP and the CBC were collected routinely on day 3 of the study, or when signs and symptoms of sepsis were present, and the stool cultures were collected on admission on day 7 of the study and at the end of the study, or if NEC or sepsis were suspected. This slide helps to illustrate the selection methods and the randomization methods utilized in the study. 150 infants were admitted to the NICU between January 2006 and May of 2007. Of those, 45 infants were excluded due to congenital malformations or death within the first 2 weeks of life, or they were excluded due to lack of parental consent. In Group A, 60 infants were given living probiotics twice daily, beginning at day 1 of life, and the probiotic utilized was Lactobacillus GG 6 times 10 to the 9th colony-forming units. In Group B, 60 infants were given killed probiotics twice daily, starting at day 1 of life, and the probiotic utilized was the same Lactobacillus GG 6 times 10 to the 9th colony-forming units. Group C contained 30 infants given placebo of distilled water twice daily, starting at day 1 of life, and of that group, 30 infants were excluded after the start of the study due to early sepsis or congenital anomalies. The infants were divided into these principal study groups by simple randomization and all infants received either the probiotic or the placebo until day of discharge. Probiotic administration was stopped if an infant was diagnosed with necrotizing enterocolitis that was believed to be a stage 2, and this is considered a more severe case of NEC. So those infants that had a milder form remained in the study. All infants included in the study were given detailed medical history and biochemical data collection, including gestational age, birth weight, sex, mode of delivery, steroid treatment, history of a maternal rupture of membranes. Also included in the study were monitoring for conditions like respiratory distress syndrome or intrauterine growth restriction. Also, other factors monitored were the type of feeding each infant had, and also the age at the initiation of feedings. This table is included in the study. It's table 4, and it's the comparison between risk estimate of living and killed probiotic versus placebo as it regards to the incidence of NEC, sepsis, and outcome. In regards to NEC, you can see that administration of living probiotic was not a risk factor in NEC. Placebo was a risk factor for NEC, and administration of the killed probiotic was actually a preventative factor for NEC. In regards to sepsis, administration of a living probiotic, or the living probiotic, was a preventative factor. Administration of a placebo was a risk factor, and the predominant organism found for this placebo group was Klebsiella, and for the killed probiotic group, that was also a risk factor for sepsis, and the Acinetobacter organism was significantly higher in the group receiving the killed probiotic. In regards to death, living probiotic administration was not a risk factor. The placebo was a risk factor, and administration of the killed probiotic was a preventative factor for death in this study. So the results of the study were that the incidence of NEC and sepsis were significantly higher in the placebo group. The living probiotic supplementation was preventative for NEC, sepsis, and poor outcome for all infants. However, specifically when referring to preterm infants in the study groups, the incidence of NEC was significantly lower in the probiotic supplemented groups compared to the placebo group. However, no significant reduction in sepsis was found for preterm infants in the study groups. Significant reduction in sepsis and NEC was found among neonates containing positive gut colonization with lactobacillus at day 7 and 14 compared to those infants without colonization on those days. The authors discussed the previous randomized control trials conducted in the area of probiotics used for NEC reduction. In 2005, Lin and Associates showed a significant decrease in NEC mortality and sepsis in infants fed breast milk supplemented with probiotics. In 2005, Bin Nunn demonstrated significant reduction in NEC among neonates fed a mixture of probiotics. In 2006, Lee and Associates demonstrated that infants supplemented with probiotic experienced significant NEC reduction, and prophylactic probiotic use was an independent protective factor for NEC. Lee and Associates in 2007 found an increase in sepsis in neonates whose stool cultures did not contain lactobacillus after supplementation with probiotics. However, this increase was not statistically significant. And another randomized control trial regarding sepsis was published in 2002 by Danny and Associates, and it demonstrated less UTI in neck in infants receiving probiotic supplementation. However, no significant reduction in sepsis was demonstrated. So the overall conclusion of the study was that both killed and living Lactobacillus GG are preventative for neck and neonates, and administration of killed probiotic limits the potential for bacterial overgrowth in the intestine. Also, positive lactobacillus colonization of the gut reduces sepsis in neck, and this demonstrates the importance of early colonization of the infant's intestine with beneficial bacteria. In preterm infants, no significant reduction was seen for sepsis, and the authors concluded that due to the complex pathogenesis of sepsis, probiotics just may not influence that condition. In the future, topics of research may include medium and long-term follow-up that needs to be undertaken to study secondary outcome variables like future growth and the well-being of the research participants. Also, another very important future research topic would be what proper and safe probiotic dosages and the timing of the intervention are necessary. Also, the adverse effects would be other additional variables that need to be studied. This slide reviews the critical analysis of the randomized control trial using consort guideline or checklist from 2010. The strengths include the title and abstract identified as a randomized control trial. The summary of the design, methods, and results were provided. Also, another strength is the scientific background and specific objectives were stated. The trial design methods and changes after commencement were included. Also, the eligibility criteria, the settings, and the locations of the study were provided. They also discussed their stopping guidelines that they used within the study. There was a table included in the study for baseline characteristics of the participants, and the primary and secondary outcomes were stated. Another strength is that the interpretation of results was consistent with other relevant studies. However, the limitations listed on the right side of the table were that the determination of the sample size was not discussed, no harms and no unintended effects were stated, and trial limitations, potential biases, or imprecision was not discussed. Also, the registry number and the name of the trial registry were not included, as well as the funding sources for the study. Another limitation that I found as a neonatal dietitian was that this study did not include infants less than 28 weeks or less than 1,100 grams at birth. And in my practice, we see a lot of infants that are anywhere from 23 weeks gestation to 28 weeks. We also see a lot of infants that are usually less than 1,100 grams all the way down to 500 grams at birth. So this would be an area for future research as well as a limitation in this study. Maybe next time a group could include infants or focus on premature infants that were less than 28 weeks and less than 1,100 grams. Thank you.